Jake Gold here, going to give a presentation on dental complaints in the ER. This is part of my QI project. It's going along with rolling out a dental box that's going to go in the A and E team fish bowls today. Will contain some supplies to better address dental complaints that I will go over in this presentation, as well as addressing the various complaints we might encounter. I want to give a shout out to a friend of mine from college, Dr. Rob Wertke. He's a dentist and helped me quite a bit with this presentation and gave me a lot of pro tips and pointers, stuff that I wouldn't have found in our EM textbooks. So thank you. So first thing I want to talk about with anatomy here. So first distinction is primary teeth versus permanent teeth. There's going to be 20 primary teeth, which are the baby teeth, and 32 permanent teeth. For our purposes, this only matters because of the need to be more aggressive with salvaging permanent teeth. By the age of 12, all teeth should be permanent, and before 6, all teeth should be primary. And between 6 and 12, your dentition is going to be mixed. So primary teeth are generally smaller and whiter and have narrower roots. If you have trouble differentiating, you can err on the side of caution and treat it like a permanent tooth. Or in the case of an avulsion, which we'll get to, you can get a Panorex, which is a panoramic dental radiograph, to help you differentiate. Because if you have an avulsed baby tooth, you don't want to replant that. Here's what a Panorex looks like if you've never seen one before. Here's the nomenclature for names of teeth. You could use the numbering nomenclature, which starts at 1 at the posterior most tooth of the right maxilla. But I think learning the names and referring to them by right, left, maxillary, and mandibular is an easier way to do it. So starting centrally and moving lateral/posterior, you have the central incisors, followed by the lateral incisors, followed by the canines, then the first and second premolars, and then the first, second, and third molars, with the third molars being the wisdom teeth. So for example, you could say something like the left maxillary canine, and that would specify exactly which tooth you're talking about, which is also number 6. And then here's individual tooth anatomy. The tooth is made up of the exposed portion, which is the crown, and then the root, which is embedded into the gingiva/gums and into the alveolar bone of either the maxilla or the mandible. And then the root is held in place by the periodontal ligament. The tooth has 3 layers: the enamel, which is the hardest substance in the human body, which I found interesting, that covers the tooth, and then the dentin, which is the tubular or porous structure, and then the pulp, which is the neurovascular and soft tissue of the tooth. Examination for dental purposes, so you should use like a tongue depressor to examine all the soft tissues in the mouth. You can use a piece of gauze to help you grab the tip of somebody's tongue to manipulate and look at the floor of the mouth. When you look at the floor of the mouth, you want to palpate the floor with one finger inside the mouth and then palpate externally with the other hand. That's important for like looking for things like Ludwig's angina. And then inspect each tooth and percuss it. This is the first improvement, as we will now have some disposable dental mirrors, so you can get a full view of the individual teeth. And then you can use a tongue blade or the back of the mirror to push down on each tooth to evaluate for tenderness on percussion and mobility. And then you can evaluate the TMJ joint for like clicking and crepitus. You can do this by putting your fingers in the patient's ears. Definitely instruct them on what you're going to do beforehand. Otherwise, you're going to start the exam and they're going to have no idea what you're saying. I kind of lump the complaints that we encounter into atraumatic and traumatic, and there's like one that's kind of overlap that we'll get to. I'll start with the atraumatic dental pain complaints. So the first one is called pericoronitis. This is pretty much a disease of the wisdom tooth or third molar, and it's inflammation and or infection of something called the operculum, which is the gingival tissue that is covering the erupting tooth. So this can be secondary to impaction of food underneath the operculum of the erupting tooth, leading to some local infection. It's going to present with pain or irritation, and it can have some spreading infection, which can cause a host of other oropharyngeal symptoms, such as like trismus if it's very severe. Exam's just going to show local inflammation or irritation of that tissue. And if it's spreading, show, spreading, swelling, and irritation. The treatment, so first thing that was kind of major that I learned, you'll see some people still using penicillin VK. Penicillin, even in dentistry now, is not really favored. Most of the time now it's going to be, or I guess pretty much all of the time now, it's going to be amoxicillin. So you're going to use amoxicillin 500 milligrams Q8 for 5 days for this. Analgesia, usually with NSAIDs, and then directed chlorhexidine rinses. So we will have now chlorhexidine rinse in our dental box, and you can prescribe that to patients as well. So you can just use one, maybe give them one, but prescribe it. Don't give them a handful. And then if there's severe features or spreading symptoms or spreading infection and systemic symptoms, then it might be something that requires IV antibiotics and talking to OMFS. So for irrigating these things, you can use the chlorhexidine, and then you can use angiocath on a syringe and direct it underneath the operculum, and you can give them something like that to go home with to irrigate with. Here's a picture of what pericoronitis looks like. Dental caries, these are cavities. I learned that the term caries is both the singular and plural of the word. Essentially, bacteria on the teeth release acid, break down the enamel. Eventually, it involves the dentin, and the caries spread along the dentin microtubules. Their presentation, it's only going to be painful when there's pulpitis, which we'll get to, so they might not have any pain with this, and usually just a simple carie won't present to the ER. Exam's going to show some decay of the tooth. Sometimes this decay happens between the teeth, and it can be difficult to see even if you do use a Panorex, and they may need specialized dental x-rays, which we don't have. So keep in mind that even though you're not seeing it, maybe they have some caries that are between the teeth. Treatment's going to be dental referral. If the pulp is fully exposed and they're really sensitive, you can think about covering it with calcium hydroxide paste if they have prompt follow-up. Otherwise, do not cover caries yourself. This is something that needs the skill of a dentist. Pulpitis, so this is something that happens when the caries get down to the pulp and there's inflammation of the pulp causing pain, which can either be reversible damage or irreversible. And reversible pulpitis, so the pulp is still able to respond and repair itself. The presentation of this is going to be pain that's lasting for seconds, and it's usually with heat or cold exposure, sometimes sweet or sour. So you'll get somebody coming in saying, oh, every time I drink something cold, I get a sharp pain that lasts briefly and then goes away. Exam, you might be able to see the decay of the tooth, or if it's between teeth, it could be difficult. You might need to percuss to elicit that, or have them bite a tongue blade. And then you could also just try exposing them to heat or cold, like, hey, drink this, does that hurt? Treatment is going to be blocks, NSAIDs, and just a note, ADA recommends against opioids for this. And no antibiotics are necessary if it's reversible pulpitis. So if it's very clear this is just the brief little pang of pain that they're getting, you don't need to give antibiotics. One thing I want to just say about blocks, I'm not going to go into detail about dental blocks. I use them all the time, and just want to give a plug for them that, I generally will look it up. It takes me 60 seconds to refresh how to do these dental blocks, and then I'm like 90% successful with getting it. You're injecting into a pretty small space and dumping a couple cc's. You're bound to hit the nerve using just the landmarks. So definitely a good tool. Don't shy away from them. Give them a shot. Irreversible pulpitis. This is just when the damage becomes irreversible to the pulp. The presentation, so now it's going to be pain that lasts for minutes to hours after some sort of stimuli. Same thing as before, hot, cold, sweet, sour. Exam, same as previously, eliciting tenderness or pain with cold. And then treatment, it's going to be the same. as previously, but this is going to require a root canal or extraction eventually from a dentist. And then antibiotics are debatable in the dental literature, and without surrounding obvious infection and timely follow-up, they're not necessary, is what, kind of the conclusion is. I talked with Rob at length about this, and what we kind of came to the conclusion is we're not going to be the greatest at differentiating if there's anything surrounding there, and a lot of our patients aren't going to have timely follow-up. So you should treat these with antibiotics from RED. So you're going to give them amoxicillin 500 TID for 7 days, or you can do 875 BID for compliance purposes. And then pulpal necrosis. This is the final stage of pulpitis. The presentation is going to be pain that's spontaneous, lasting hours and days. The treatment for this is going to be root canal or extraction eventually. These definitely need antibiotics. And you can do dental blocks as noted before. And then for all these, clindamycin was the traditional second line for penicillin allergy, but the latest dental literature now recommends azithromycin and the usual Z-Pak dosing, so 500 one time and then 250 for 4 days. The next topic, so it's a mouthful, periradicular periodontitis and periapical abscess. So I lumped these together because clinically they're indistinguishable unless you can establish that there is pus or purulence. Then it's a periapical abscess. But really it's a continuum of disease. So it is going to be extension of pulp disease and necrosis. So you're going to have a pulpitis that extends to the tissue surrounding the root and the apex. And a periapical abscess is indistinguishable even on radiographs. The presentation, they're going to have pain and swelling around the tooth. Exam's going to show pain with percussion of the tooth with that gingival swelling. And then, this can be show pain with percussion without cold sensitivity, which may distinguish it from having a big carie. If there is an abscess, sometimes there's a draining fistula known as a purulus. Also, the abscess can erode through the cortical bone, which results in a palpable fluctuance. So not all of these are an abscess we can get to. Usually a periapical abscess is something that's locked between the tooth and the alveolar bone, not something we can get to. Panorex will show a periapical radiolucency, and that's, again, not going to be something that distinguishes whether it's either of these conditions. Both of them will show that. Treatment, if there is fluctuance like we talked about, so it's eroded through the bone, then you can drain it. Otherwise, you're going to use antibiotics in the same regimen as for pulpitis. NSAIDs for pain control. You could try dental blocks. If you are draining it, don't try to anesthetize through the diseased gum tissue. Do a block. Special considerations for this. If this happens to be occurring near the first or second premolar on the mandible, you should try not to be quite as aggressive because there's a mental nerve that erupts near there. So just try needle aspiration with that and give them antibiotics and referral. This is just a diagram showing you on the far left there's periapical abscess, showing you it forms near the apex of the tooth down at the root. Periodontal disease. So this is also called gingivitis, and it's gingival inflammation and bleeding, which progresses to periodontitis, which causes destruction of alveolar bone and gingival resorption and destroys the periodontal attachment and leads to tooth loss. This is usually painless and won't come to the ED unless somebody's like, hey, all my teeth are getting loose and my gums are going away. This requires dental cleaning, improved hygiene. Sometimes they need surgery for this. Give antibiotics, same as the previous regimen for this. And this is showing you the periodontal disease second from the right there, with erosion of like the gingiva and the attachment ligament. And then gingival abscess. So this is an abscess that's formed at the margin of the gingiva. Usually this is from a foreign body that gets stuck there. Sometimes it's like a broken toothbrush bristle. The presentation is going to be acutely painful, and they're going to have like rapidly increasing swelling and pain over a day or two. Exam, you'll see swelling at the gingival margin, and you might see the foreign body there. There might be some expressible pus. Management, remove the foreign body, irrigate this with saline or chlorhexidine, and instruct them on home irrigation like we talked about. And then for this, actually, because it's very superficial, antibiotics aren't necessary for this one. This is showing you the gingival abscess second from the left there. It's right at the gum line between the gum and the tooth. Then periodontal abscess, so abscess forming in the periodontal pocket, usually from debris and plaque and gingival disease. So they already have like gingivitis and then they get an abscess in that space. It's going to present with severe pain. If it's small, just do chlorhexidine rinses twice a day with antibiotics. If it's larger, you might need to do an IND of this. This would be like a good one for Panorex to help differentiate what exactly is going on. So periodontal disease, again, second from the right there, showing you where you get that disease in gingivitis, and an abscess can form in that pocket. ANUG, so this is kind of the extreme dental issue that we can get here. So this is acute necrotizing ulcerative gingivitis. It's an aggressive destruction and ulceration and necrosis of the gingiva. It can progress to include the periodontum, in which case it's called necrotizing ulcerative periodontitis, or it can lead to a condition called noma, also called cancrum oris, and that's when it spreads to the cheeks and lips and facial bones. This condition, very rare in the US, but that is commonly fatal actually. This is usually an opportunistic infection, so this is all more common in Africa and where HIV is very endemic. The presentation, you're going to see pain and gingival bleeding. They may have some systemic symptoms. They'll complain of a foul metallic taste in their mouth. Exam, you'll see some bleeding and ulcerated, and the pathognomonic is punched out gingival papillae. So the gingival papillae, the little part of the gum that sticks between each tooth, you'll see like punched out lesions of that. And then they'll have fetid breath, tooth mobility, lymphadenopathy. Of note, herpes gingivostomatitis can appear somewhat like this, but it won't have the classic punched out papillae, and they'll have vesicles with that. So to manage this, you're going to have them rinse their whole mouth with chlorhexidine twice a day. They need referral urgently for professional debridement, and then amoxicillin and metronidazole, both 500 TID. You can use Clinda or zithromycin alternatively for penicillinergic. And then you're going to want to think about working up and offering these people workup for immune compromise. Here's a picture of what that looks like. You can kind of see here where the papillae are punched out. Here especially too, on the sides. That's a good example. So the next, this is where there's overlap between atraumatic and traumatic. So cracked tooth syndrome or split root. This can happen traumatically or atraumatically. With atraumatic, it's usually like a wear and tear, or they might have bruxism or tooth grinding. This is sometimes described as being a green stick fracture of the tooth, or an incomplete fracture. And the presentation history of restoration is common, or an upward blow to the jaw can cause this. And it's going to be variable from asymptomatic, or if the pulp is involved, It can be similar to pulpitis with pain and sensitivity and pain with chewing. Exam, it's often difficult to see this even with an x-ray. You may just have to, diagnose this clinically if there's pain with percussion and they had a convincing story and nothing on x-ray. Treatment, avoid chewing on that side. Give them pain control, have them see a dentist. Here's what kind of some of those cracked tooth things look like. You can see some incomplete cracks in here, not a full fracture of the various parts of the tooth. Again, kind of a diagnosis of exclusion if you can't fully see it on x-ray or on exam. Moving on to traumatic dental complaints. So we'll start with dental fractures, which I personally always think of these crown fractures, the Ellis classifications. There are also crown root fractures and alveolar bone fractures, which we'll discuss, but I want to discuss the crown fractures first. So Ellis class 1. So the presentation of this, they're going to have trauma. They'll complain of a change in their dental appearance, change in their bite, or they might feel a jagged edge on their tooth. Pain should be only from associated injuries because the pulp remains untouched in this kind of fracture. So the fracture itself shouldn't be what's causing them pain. Exam's going to show part of the tooth is missing. The underlying portion should still look chalky white, no pink blush, no bleeding, no sensitivity. Management, you can file down the jagged edge, or if you recover the portion of the tooth, you can keep it in a solution which we'll discuss and bring it to the dentist, and they may reattach it. But Rob tells me that often they just kind of make something synthetic, so I wouldn't worry too much about that. If there's other wounds, you may need to do radiographs to find the missing portion. And like, for example, if they have like a big laceration on their cheek, then you may need to do radiographs, make sure that missing portion isn't stuck in their cheek. Here's that diagram again. Ellis class 2, so enamel dentin fractures. This is going to be a fracture that's going to have sensitivity to hot or cold, or even breathing. The air just moving over the tooth can be sensitive. And this poses a risk of pulpal necrosis given that there's communication between the pulp with the dentin microtubules. Exam, you'll see creamy or ivory yellow exposed dentin, and then you may, if it's a very deep fracture, you may see kind of a pink blush underneath, seeing the pulp through the dentin, but there will be no bleeding. They'll have some sensitivity with this. Management, if they have definitive management that can be done shortly, so say they say, oh, I just wanted to get checked out, but I have a dentist appointment tomorrow, then you can refer them. So it has to be like 24 to 48 hours. You're going to want to save the fragment, and then our temporizing measures, if you can see the pulp, or if it seems deep or there's sensitivity, you're definitely going to want to place a layer of calcium hydroxide paste. You're going to need, and we'll get to how to do that, that's another thing that's now in the dental box. You're going to want to anesthetize this before you really do anything, because just touching this to dry it or blowing on it with oxygen is going to make it very painful. So do a dental block. And here's what the Ellis class 2 looks like. And then Ellis class 3, enamel dentin pulp fractures. So this is going to be a very painful fracture. They're going to have exposure of the pulp. You'll see pink color and bleeding. When you wipe with gauze, there should be visible blood. And there's usually excruciating pain, but if the trauma disrupted the nerve, it may be painless. And then management, anesthetize this, control the bleeding with gauze, and then calcium hydroxide paste to cover it. And you're going to want to refer this. Most of them are going to need root canal therapy. In children, definitive management is even more urgent because their dentin is thinner. Here's that diagram again, and here's our improvement. So real quick, you're going to cover it with this calcium hydroxide paste. You're going to want to dry things first. So for both this and splinting, when you dry things off in the mouth, you can use a lot of gauze. And then on top of that, you can use the oxygen off the wall, just kind of cut the nasal cannula and then use that directed oxygen to blow dry whatever you're applying things to. And here's the calcium hydroxide paste we now have.
The dental box contains Pre-Line brand calcium hydroxide paste. It comes in 2 distinct tubes. The contents of each tube are mixed together to activate the cement. Place equal amounts of the catalyst and base onto your mixing pad. A small amount of each is usually plenty if you're only covering one tooth. Using the stainless steel mixing spatula, mix the catalyst and the base thoroughly until the mixture begins to thicken. This usually takes about 20 to 40 seconds. When the calcium hydroxide thickens up, scoop it up onto the flat blade of your spatula. Apply it to the fractured surface of the tooth, making sure all of the exposed dentin and pulp are covered. Remember, the tooth must be dry in order for the calcium hydroxide to adhere properly. The moist environment in the mouth will speed up the hardening process of the calcium hydroxide. Have the patient keep their mouth open for 10 or 15 minutes after applying the paste to the tooth. A rolled up gauze roll positioned away from the site of the covered tooth will help the patient keep their mouth open.
And so for that, we do have some mixing spatulas, and we have those mixing pads as well. The mixing spatulas turned out to be pretty large. So for this, I would say use the back of like the tweezers from a suture removal kit to mix it up and then kind of use it as the spatula to apply onto the tooth. Crown root fracture. So this is rare. It's a fracture extending down from the crown into the root, and it may or may not involve the pulp. Presentation, variable amounts of pain and sensitivity. Exam's going to show a loose fragment in a coronal and sagittal plane, and you may be able to see this on x-ray, but usually require those special dental x-rays. Management, if it's loose, obviously like a Volst, you can reposition and then stabilize with Copac splinting material and have them follow up, and we'll get to the Copac, which is another thing now in the dental box. So here's what a crown root fracture looks like. It's just fracture extending all the way down into the root of the tooth, and it could, as you can see, extend kind of on the side of the pulp, so it might not involve the pulp. And then root fractures, so it's all in the name. It's just a fracture that goes across the root of the tooth, so by definition it's going to involve the pulp. Presentation, you're going to see a loose crown or even an avulsed crown. There will be bleeding and pain and sensitivity. Management is going to be splinting this. And this is one where you might want to get a consultant to try to save the tooth. Otherwise, you can just do your best and make sure you get a Panorex after the fact to confirm that it's in an adequate position and approximated appropriately after you splint it. And here's what a root fracture looks like. And here is the splinting material, which we also will be using for a few other things coming up in terms of luxation injuries. So same thing in terms of drying the teeth before you apply this. This is called Copac.
The dental box contains Copac, which is periodontal paste. It works very well to stabilize loosened teeth in a variety of different situations. It also works very well in the treatment of gingival lacerations, often making suturing unnecessary. It comes as a catalyst and a base. First, squeeze equal amounts of each of the base and the catalyst onto a large mixing pad. Next, mix the catalyst and the base together using a wooden tongue blade. It will take approximately 30 to 60 seconds of vigorous mixing before the periodontal paste thickens up and becomes more difficult to mix. When it becomes thick, scoop up the paste with the tongue blade and place the paste and the tongue blade into a basin of water. While the mixture is sitting in the water, use the water to soak your gloves. The Copac will stick to anything that is dry, so your gloves must be completely wet. Now, with wet hands, pull the Copac off of the tongue blade and roll the paste into a cigar shape. If the Copac begins sticking to your gloves, dunk your hands back into the water and get them wet. Once the Copac is rolled up into the shape of a cigar, it is ready to apply to the teeth. When applying to the teeth, remember to extend the Copac to one stable tooth on each side of the loose tooth. It is applied to both the gingiva as well as the enamel. Remember, the gingiva and the enamel must be dry. If there's blood or saliva on the teeth, the Copac won't stick, so make sure the teeth are dry. Try not to get the Copac over the occlusal or biting surface of the tooth, as this will interfere with the patient's bite. You can apply the Copac to both the facial and oral surfaces of the teeth if necessary to stabilize the tooth. In my experience, if you really work the paste into the interproximal spaces of the teeth, you usually can get adequate stabilization by just applying to the facial surface.
Of note, I have used a sort of MacGyver device for that before we got this material. If you're in a situation and you don't have that stuff, you can use the metal malleable piece off the nose bridge of an N95. You can cut that and mold it into shape, and then you can use Dermabond actually on the teeth and then have them follow up. Next thing we'll talk about is luxation injuries. So these are injuries to the attachment apparatus. So some general notes about this. These can sometimes have alveolar ridge fractures, as we'll see, and this might need timely management by a dentist or OMFS. If these get contaminated, you're going to prescribe amoxicillin. And then for primary teeth, you're going to leave those alone, even in the case of an avulsion, because it can damage the permanent teeth or ankylose to the bone if you try to replace or adjust a primary tooth. And then you're going to want to refer them to a podontist in those cases. They may need a space maintainer if they have an avulsed primary tooth. The first is concussion. This is basically just you hit a tooth, it hurts, it's not even loose, there's nothing on the radiographs. Just give them NSAIDs, tell them to use a soft diet, and then refer them to a dentist so they can make sure nothing else is going on. Subluxation, so this is going to be a tooth that is mobile but without any radiographic dislodgement, and it's just going to have pain, maybe some bleeding along the gingiva. Treatment for this, you don't need to splint these unless they're really extremely mobile. Otherwise, you're just going to, soft diet, pain control, refer them to a dentist to rule out anything else. Extrusive luxation. So this is when a tooth is essentially partially avulsed straight out of the attachment apparatus. It's going to present after trauma, and their tooth is going to look elongated with some mobility and gingival bleeding. To manage this, try to get an x-ray to look for a fracture, because if they have a root fracture, it can look just like this with the tooth kind of hanging out after the root is cracked. But essentially, this is going to need to be repositioned and splinted. Essentially, just push it back in and then splint it with the Copac, which you'll do for a root fracture as well. So it's up to you. You could probably just get away with pushing it back, splinting it, and then getting the Panorax. And that's what this looks like with the tooth kind of pulled out. Lateral luxation. So this is a more extensive injury with the tooth displaced either labially or lingually, so like towards the face or towards the tongue. And then it's going to have associated alveolar bone fractures. Exam's going to show the tooth displaced, as we just discussed. You're going to want to get an x-ray or CT for this, and then you're going to want to realign things, which may require more force than you anticipate. I've done one of these, and you have to pull pretty hard, and then it kind of snaps back into place. Get the imaging, because there's going to be some sort of alveolar bone fracture. And if it's an extensive fracture, you may want to consult OMFS. But if it's small, you can just splint and have them follow up. I've also had one of those that was really extensive and had OMFS come in, and they even had trouble reducing it at bedside and had to put some special bar device in. And here's what that looks like with those two mandibular central incisors that are laterally luxated. This would be like a lingual lateral luxation. And here's why there's going to be alveolar bone fracture. As you can see, in order to dislodge it in that direction, essentially that alveolar bone has to break. Intrusive luxations, so these are really serious. It's the tooth pushed up, and it causes damage to the alveolar socket and periodontal ligament. But your management here, you're actually just going to leave these alone and let them erupt on their own, and just have them closely follow up with a dentist. Sometimes they have to put special braces-like devices to help them erupt properly. And here's a picture of that. This person looks like they maybe have a LS1 fracture and an intrusive luxation of that. Avulsions. So this is when the tooth is gone. And the presentation, their tooth is gone. Exam, their tooth is gone. The management of this, it's pretty urgent. You want to replant this as soon as possible. If you're going to store it or you should store it really while you prepare the socket, there's a specialized Hanks balanced salt solution, but this is equivalent to using milk, and that is also equivalent to using Pedialyte. We have Pedialyte around. You can go and grab that from Main Supply. And then the next options, if you're in a pinch and not at Sinai Grace, you can use sterile saline, or you can use the patient's saliva. You're going to hold the tooth only by the crown. Don't hold the root. And then rinse it off gently. Do not scrub it because you can scrub away some of the attachment apparatus. And then to prepare the socket, anesthetize, and then you're going to irrigate away the clot that's in the socket. And then you're going to use firm pressure to push it back into place. And you can have them bite down on some gauze to stabilize it and make sure their bite's proper before you splint it. Again, splint using the Copac. If it's contaminated tooth, give them tetanus prophylaxis. And then also, if it's contaminated, prescribe amoxicillin. Try to get the orientation right for this, but timely replantation is the most important thing. Even incorrect replantation in a timely manner is way better than delayed. Outcomes are good if you get it back in less than 20 minutes. 20 to 60 minutes, make sure you put it in one of those solutions briefly before you replant, and the success rate at 20 to 60 minutes is more marginal. And then greater than 60 minutes, essentially the tooth is going to die. But you should still attempt replantation as it'll preserve the contour of the alveolar bone, basically just a space holder for the socket. Complaints related after dental or orthodontic procedures. So post-extraction pain, essentially get a tooth pulled. Usually pain and edema will peak at a day or two after. People can also have trismus early on. Treatment, just ice packs, elevate the head of the bed, give them NSAIDs. Post-extraction alveolar osteitis is a mouthful, and it is what we commonly refer to as a dry socket. Usually this is 2 to 3 days after getting a tooth pulled, and it's usually a disease of the third molar or getting your wisdom teeth extracted. Essentially, you lose the clot that's covering the socket, and you end up with exposed alveolar bone, leading to a local osteomyelitis. The presentation, they're just going to have exquisite pain after this. An exam, you'll see a dry socket. You'll be able to see the bone in there. Treatment, so pain management, they want to irrigate this. You're going to irrigate it with chlorhexidine and give them some of that. And then packing it is kind of controversial, but we will now have dry socket paste, and you can use that to pack. It's going to come in these little tubs. So you know, once you irrigate it out, clean it out, anesthetize, and then dump out or scoop out what you're going to use of this before you touch anything, because it's just going to be a few tubs of this, and I don't want to contaminate the container. And then you're going to use that and pack it in the socket. You can use tweezers for that. And then if there's signs of, systemic or spreading infection, you can give antibiotics, same as previously discussed. Post-extraction bleeding, this is self-explanatory what it is. Management, you can put direct pressure by having them bite down on a 2x2. You can also soak that 2x2 in TXA. You can inject some Lido with epi. You can use gel foam. And then if you need, some say you can loosely suture the gingiva. But if you do it too tight, you can cause necrosis of the gingival flap. So very loose, kind of bringing the gingival flaps together. If it continues, you may need to call OMFS or ENT. Post-restorative pain after somebody gets fillings or crowns. Sometimes they can have improper occlusion of the pulpal tissue, so they just basically get pulpitis. NSAIDs, they may need narcotics if it's really bad. Offer them a dental block. And then orthodontic appliances, broken or bent wires, bend them back, do not cut them. You'll just create a new jagged edge. Rarely, if you need it, you can actually cut the rubber from the brackets and remove the wire. Try to avoid that. You'd be making a lot of work for their orthodontist. Periimplantitis, this is just a general term for post-procedure disease, similar to periodontal abscess with similar treatment. Remove plaque and debris, irrigate, and then refer them back to their dentist. Lost crown or bridge. So basically these are caps that go over teeth. So if there's a damaged tooth, rather than like pulling it and putting a new implant in, they file the tooth down and put a cap over it. And that's the crown. And if these fall out, we can actually put them back in, at least temporarily. So we will have Temrex dental cement that you can use. Essentially what you're going to want to do is thoroughly clean out the lost prosthetic, and then you're going to put Vaseline copiously on the outside of it, and then dry everything in the mouth, and then you're going to put some cement in the prosthetic and replace it, and then have them bite down to make sure their bite's okay. And some of that cement's going to kind of ooze out the side, which is why you have Vaseline on the tooth, and you just flick away the excess cement. Here's what that looks like if you're not familiar with the concept. And here's what a bridge looks like. So you're kind of replacing a lost tooth by putting a cap or crown with a prosthetic bridge over the two adjacent teeth. And that's it. So the contents of the dental box will have the calcium hydroxide paste, the Copac, will have mixing pads and spatulas, Temrex dental cement, dental mirrors, the dry socket paste, and chlorhexidine rinses. Let me know what you think, and tell me if you have any feedback or anything that needs to be adjusted. Just a quick note, these boxes turned out to be pretty large, so I think what I'm going to do in the coming weeks is I'll figure out how to combine those ENT boxes and just put all the materials in the same box. But for now, we'll have the separate dental boxes that are going in the A-side fishbowl and in E-team. Thanks for your time, and I hope this helps you guys out.